This is Dr. Howard Strassler speaking on caries as an infectious disease, Module C, Classification. Black's classification of carious lesions includes 5 classes, the 6th class being defined by Schultz in the 1950s. And these 6 classes of carious lesions really of pathology to the hard tooth structure are very distinct. G.V. Black's legacy to dentistry really was a systematizing of all of dentistry, not just the classification of lesions that we'll be restoring, but also the 7 steps of cavity preparation, defining hand instruments, burrs, in fact being instrumental in the development of the formulation for amalgam. Caries is classified according to the surface type. We can have pit and fissure carious lesions and smooth surface carious lesions. Pit and fissure carious lesions really refer to class 1 only by definition, and we'll describe that definition in a few minutes. Smooth surface carious lesion really extends to class 2s, class 3s, class 4s, class 5, and class 6. All of these are on smooth surfaces of teeth, whether it be a proximal surface, whether it be an incisal edge or a cusp tip, whether it be a facial or lingual surface. When we speak about carious lesions, the bacterial infection of hard tooth structure, we're really talking about a carious lesion continuum. And when we speak about that, we start speaking about the fact that a tooth with no caries is sound tooth. The initial carious lesion is a demineralization of the tooth, and in fact there's an equilibrium between demineralization and remineralization of the tooth. That the tooth, in fact, due to the saliva, due to the buffering capacity of the saliva, its immunoglobulins and the impact upon the bacteria, that as demineralization is occurring, that the tooth can remineralize. That when we're evaluating the carious lesion radiographically, if we see half the thickness of the enamel has been penetrated by the carious lesion, and specifically bite wing and PA radiographs that show the interproximal surface, that it tells us that things are happening due to the bacterial infection. That we can see a definitive enamel carious lesion radiographically, visually on a radiograph, where the enamel surface will be intact. In fact, the carious lesion can extend to the dentinal surface radiographically, and still the enamel surface will be intact. In fact, at this point, where we are into the dentin, that the enamel surface is intact, it's still remineralizable. It's when we see the slight enamel surface cavitation and the demineralization has spread to cavitate that surface, a roughness, a hole in the tooth, that's when we need a restoration. So let's look at the different classifications of carious lesions by their definitions, by their appearances. Class 1 carious lesion refers to pit and fissure caries to include posterior occlusal surfaces, facial and lingual surfaces that are pitted, buccal pits of molars, lingual pits of anterior teeth, and lingual pits of molars, especially maxillary molars, the cusp of Carabelli. On this line drawing, we can see a demonstration showing on the maxillary first molar a carious lesion, on the occlusal surface on the distal extending to the lingual fissure. We could see it on the occlusal surface on the mesial. Although there's a cusp of Carabelli of this maxillary first molar, there's no caries there, although it would not be unusual to see a carious lesion in that area. On the maxillary premolars, we see a carious lesion just in the fissures pits of the premolars. On a mandibular molar, as the lower line drawing demonstrates, while there's an occlusal carious lesion, it's demonstrating the occlusal carious lesion extends through the buccal fissure, and that we have a buccal pit on the facial surface that has a carious lesion. So class 1, its definition being pit and fissure caries. In fact, on national board questions, it's not unusual to have a question in terms of what's the progression of the carious lesion for pit and fissure, and that it'll be described as two cones base to base, or two triangles base to base, or two V's where the opening of the V is at the DEJ, and in fact the initiation of the carious lesion, the tip of that cone, of that triangle, is at the pit itself, at the fissure. It extends along the enamel, becoming wider until it reaches the DEJ, where the base of that triangle is at the DEJ, and then extending from the DEJ, that width of the base of the triangle then becomes narrow as the carious lesion extends into the dentinal tubules, the leading edge of the bacteria. And so these are clinical pictures of carious lesions in pits and fissures. That notice that they can be localized or extending along all the fissure. In fact, when we talk about conservative preparations would restore and prepare just those areas where the carious lesions are present, and we might then extend a sealant over susceptible pits and fissures that aren't carious. And so class 1 carious lesions, while being predominantly on the occlusal surface, can extend to the lingual. And if you look at the image on the right hand side of the maxillary first and second molars, let's look at the second molar. The second molar has an occlusal lesion in the mesial that we diagnose as being slightly cavitated, and it extends into the buccal groove, into the buccal fissure. On the distal, we have an occlusal lesion that extends to the lingual fissure, and in fact the preparations would be extended and have an outline form that would mimic the extension of the carious lesion. On this maxillary second molar, if you look, you'll notice that there's an auxiliary cusp, an accessory cusp on the lingual, similar to the cusp of Carabelli, and that there's an initiating carious lesion on that lingual cusp. The maxillary second premolar has an occlusal carious lesion, and as we look towards the left, you can see that whereas on the second premolar the lesion extends the entire fissure, but not the mesial and distal fossas completely, yet on the first premolar the transverse ridge and the fissure, the groove going through the central fossa, is not carious, but each of the mesial and distal fossas is carious. The class 1 lesion could include a lingual or buccal pit. As we look to the image on the right, you can see in the maxillary anterior that the maxillary central incisor, one of the central incisors, has an amalgam restoration. That's the restoration that was placed for the lingual pit. We can see lingual pits on the lateral incisors and the other central incisor that might need restoration if they're carious. The image on the left-hand side, we can see that there's a buccal pit on a mandibular molar that's been cavitated, and that's a carious lesion. Class 2 caries refers to smooth surface caries on the proximal surfaces of posterior teeth. The progression of the caries once again can be defined as two cones tip to base. Base tip to base, meaning that it starts wider on the enamel surface, the smooth surface, becomes narrow as the lesion extends to the DEJ, where it's the tip of the lesion, and then the base of that lesion extends along the DEJ and then extends as a tip of that triangle, of that cone, following the dentinal tubules. That's a classical view of the carious lesion. Clinically, we make the diagnosis of class 2 caries based upon radiographic information, and the diagnostic radiograph is a bite wing radiograph. And so we look at the progression of caries as being two cones, two triangles, where the base of the triangle on the enamel surface is wide. It extends to be narrow to be a tip to the DEJ, and then the tip spreads along the DEJ, so there's a base of that lesion at the DEJ, and then it extends into the dentinal tubules, being the tip of that cone of that triangle. And this is what we see on Class 2 interproximal lesions. It'll be very similar with Class 3 interproximal lesions of anterior teeth. And so Class 2 are smooth surface carious lesions on the proximal surfaces of posterior teeth. In fact, the initiation of Class 2 lesions is below the contact area. Let's take a look at these radiographs of Class 2 lesions. On the right-hand side, we see a very definitive Class 2 lesion on tooth number 4. You can see the enamel is substantially eroded by the caries, demineralized. In fact, if I were to take an explorer, this would be cavitated. You can see it extends along the DEJ. As we look to the left-hand side, you can see an initiating carious lesion on a mandibular second premolar. And in fact, you can see on the dentinal area that there's been a dentinal lesion. This may or may not be cavitated. Can we make a diagnosis on the distal surface of tooth number 20? And the answer is no, because we have overlap of the bite wing. We'd need to make an additional bite wing that would show the distal surface without overlap. The very solid white structures on this radiograph are amalgam restorations. Class 3 carious lesions refer to the proximal surfaces of anterior teeth, and once again, Class 3s, like Class 2s, initiate right below the contact area. In fact, the gingival margin of the tooth preparation will have broken contact because that's where the carious lesion initiated. Its classical appearance is very similar to Class 2s. We make the diagnosis, and if you look at the lower left-hand side, of two mandibular incisors, where I'm using shining a bright light, I'm demonstrating the shadowing I can see through the enamel, and that I will be able to see that the lesion has extended through the enamel into the dentin. It may or may not be cavitated. When I take a look at a radiograph of a Class 3 lesion, and we'll look at number 10, the maxillary left lateral incisor, we can see shadowing on the proximal surface on the mesial. I can't say if it's a mesiofacial or a mesiolingual because that determination will be made by where the lesion is located on the tooth. And I'm looking, if I look to the right, I can see a different view of that lesion, and I can see it's substantial. It's through the enamel surface into the dentin. And so the progression of Class 3 smooth surface caries is the same as a Class 2, where the progression is wider on the enamel, the base of the triangle. It becomes narrower. The tip goes to the DEJ, dentino-enamel junction. It then spreads along the DEJ, so the base of the triangle of the cone is wide at the DEJ, and then the tip extends into the dentinal tubules being much narrower. Class 4 carious lesions, or lesions on the proximal surface of anterior teeth that include the incisal edge. In fact, Class 4 are not necessarily carious lesions, but Class 4s can be anything that removes that incisal edge. If we look at the image, the clinical image of tooth number 8 and 9, we can see that there's been a traumatic fracture of 8 and 9. The patient fell in the concrete. Perhaps they were hit in the mouth by an athletic, by a racket. But they've fractured those incisors. There's no evidence of caries, but that's a Class 4. The radiograph on the right-hand side shows a large Class 3 lesion that became a Class 4. That the lesion initiated below the contact area. The patient didn't come in for regular care. It got larger and larger and larger until the enamel was undermined at the incisal edge. The enamel broke away, and this Class 4 is a carious lesion. So class 4s that we see clinically are typically traumatic fractures of the incisal edge, as we see on tooth number 9 on this clinical case. Although it's not unusual when replacing a defective class 3 composite resin that's very close to the incisal edge that the enamel will break away because it's fragile and it fractures. Or the carious lesion can extend and undermine the incisal edge that when you're removing the caries you realize that you can't maintain the enamel and you need to remove it during the preparation. And in this case we're seeing a clinical view of a lateral incisor where we have a carious lesion that has, in fact, caused the enamel of the incisal edge to fracture. Please notice the attrition of the incisal edge. This attrition isn't a class 4. We'll speak about attrition later as it relates to it being a class 6 lesion. But this would be a class 4 incisal edge fracture with the presence of caries. And I want you to notice from this carious lesion that's undermining the enamel in the facial, look at the halo effect of the demineralization of the internal enamel, this white opacity of the tooth. Class 5 caries refers to smooth surface caries on the facial and lingual surfaces of anterior and posterior teeth at the gingival third. It may involve the cementum or dentin as well as enamel surface. In fact, we can see either class 5s as being caries or eroded areas, notching of the tooth. But let's look at the class 5 carious lesion involving the facial surface. It may be on the enamel. It may extend to the dentin. It may initiate on the dentin. In the clinical image to the right, you can see the class 5 carious lesion right at the cervical line. A lesion of neglect. The patient didn't maintain their oral hygiene. The plaque sat on the tooth, cariogenic plaque, for an extended period of time, demineralizing the enamel and extending through. If you take a look at the mandibular second molar, you can see that an amalgam restoration has been placed on that second molar on the facial surface due to a class 5 carious lesion. And in fact, the caries travels along the DEJ and it's wider, and hence the outline form of this amalgam is substantially larger than the carious lesion we see on the mandibular first molar. And so class 5 lesions are demineralization with softening. On the left-hand side you can see a carious lesion on the on the canine, and this is soft and sticky. In fact, it's leathery caries. It's on the enamel, but now it's extending onto the dentin surface. On the right-hand side, and I'm sorry that I don't have a scratch and sniff card for you because this is pretty gross, due to long-standing bacteria plaques, cariogenic plaques sitting on these amalgam restorations, we can see we're getting recurrent decay around the margins. And we'd want to clean these teeth before we really know the diagnosis. But these are defective restorations due to recurrent caries. And to restore these, we'd need to remove the entire carious lesion to an amalgam restoration to see the extent of the lesion so that all margins are on intact tooth structure. Class 5 lesions can also be non-carious. They can be due to erosion, abrasion, abfraction, or combinations of the three. And here on the upper clinical image, you can see that we have notching of the mandibular incisors, and there's some staining of that area. These are hard and shiny and resist the penetration of an explorer. These would be restored if they were sensitive, if they were unesthetic, and in a later lecture we'll be talking about when we make decisions to restore these non-carious cervical lesions, NCCL, non-carious cervical lesions. In the lower clinical image you see the maxillary incisors. In fact, you notice that number 8 has a much larger lesion than number 9. Well, this patient is a smoker, and that's where the smoke comes in when they drag from the right-hand side. Chemical erosion and softening of the dentin combined with tooth brushing with an abrasive toothpaste to remove any stain on those surfaces, and hence we have this smooth surface, very rounded Class 5 non-carious cervical lesion, NCCL. Class 6 lesions, defined by Schultz, are lesions that are pit due to microfracture of the enamel or wear defects on the incisal edges of anterior teeth or cusp tips and of posterior teeth. Lesions can be carious but don't need to be. In fact, in the line drawing that we're seeing, you can see the cusp tips are worn on the lingual of the maxillary first molar. They're still in the enamel. It's depicting on the mesiobuccal cusp of the maxillary first molar that it's worn through the enamel to the dentin, and in fact it cups out, similar to a teacup, where it's deeper in the central area than on the edges, but yet the occlusion is only on the edges, and typically this lesion of attrition is due to wear on the tooth. We can see in the cusp tip of the canine that it's worn through the enamel into the dentin, and you can see by the shadowing and the line drawing it's giving us the feeling that if I take the Explorer, I'm going to drop into a valley into the dentin. So here are some clinical cases demonstrating Class 6 attrition, wear of teeth. Let's look at the upper left-hand side of the mandibular molar, and you can see that on all four cusps of this mandibular molar, we see Class 6 lesions. If I run my Explorer over these, the enamel is very flat on the cusps themselves, and I drop into these valleys of dentin. We don't fully understand, other than attrition, of what causes them, why they are susceptible for some patients and not others. We think it may have to do with how the tooth formed and the calcium that's present. And in fact, these teeth may be hypocalcific, that there wasn't as much calcium available when these teeth were forming. If we look at the upper right-hand side, you can see attrition of the incisal edges and the cusp tip of the mandibular first premolars. We've worn through the enamel, and you can see the dentin. The dentin's picked up stain over time. A patient might want restoration because of the fact it's no longer aesthetic. These may or may not be sensitive. Typically, they're not very sensitive. Typically, lesions of attrition of these incisal edges are older patients, versus on the molars, when we see wear of these cusp tips, like on the upper left-hand side, that these are younger patients. It would not be atypical to see this in patients who are in their 20s and 30s. On the lower clinical image, you're seeing a patient who's in their 80s where you see significant attrition. And you might say to yourself, why weren't these restored? And in fact, they don't hurt, they don't cause any problem, other than we see that they're there. And decision-making to restore these Class 6 lesions is really all over the place. Some people want to restore them, some don't. That if we restore them, how do we restore them? And later in this course, we're going to talk about how we restore Class 6 lesions and what the durability of those restorations are. In some cases, we can see these Class 6 wear lesions of cusp tips or incisal edges that are combined with microfracture. Those microfractures create mini microscopic pits that are then susceptible to becoming carious. You'd know a Class 6 lesion in classmates, younger people that you know, when you look at canines, maxillary canines especially, where we don't see that sharp cusp tip that we see in a very young erupting tooth, but in fact they flattened off. In many cases we see this flattening in patients who have had orthodontic treatment. And so on this maxillary canine we have a Class 6 lesion. You can see the enamel halo around there that's been flattened off, and in fact the cracks in the enamel and to the dentin have led to a carious lesion that needs to be restored. Restoration would be done with a number 1 round burr or perhaps a 330 burr about 1 millimeter into the tooth. You've just viewed and listened to a lecture on Caries as an Infectious Disease, Module C, Classification of Carious Lesion. This is the end of the 3 modules for this lecture.